Greetings from the University of Colorado School of Medicine and Children's Hospital, Colorado. My name is Glenn Furuta, and it's a real privilege to be here today to speak to the LASPGHAN working group on eosinophilic esophagitis on the topic of eosinophilic esophagitis and a number of different features. My disclosures are shown here, which will not influence my presentation today. I wanted to start with this slide that just shows a historical timeline of inflammatory bowel diseases compared to eosinophilic esophagitis. Inflammatory bowel diseases has a long and storied history dating over 150 years now since its initial identification, whereas eosinophilic esophagitis only has been around about 35 years now and has about 30 times less publications to support its clinical work. So my first point for especially all of the trainees in our audience and junior investigators is that we need more and more solid research on eosinophilic esophagitis to improve the care of our patients. Let's start with a case history that really supports many of the different important elements that are important to eosinophilic esophagitis. This is a patient, a cautious traveler. I saw him when he was a 10-year-old boy who had been on a cruise and had to be airlifted off because he had a food impaction. He had a history of allergic diseases and on further questioning had repeated episodes of food sticking, but no interventions were performed. This is the endoscopic appearance, which shows the typical white exudates and furrows seen in eosinophilic esophagitis, and his mucosal biopsy demonstrated the requisite number of greater than 15 and up to 40 eosinophils in this case to make the diagnosis of EoE. He was treated with topical steroids and improved significantly, but then was lost to follow-up for a number of years. When he reappeared last year, he had stopped taking all of his topical steroids. He had progressive dysphagia with repeated food impactions and had a 7 millimeter stricture and was dilated, as shown here. And just to remind everyone, 7 millimeters is the size of a straw, and one can imagine eating through a straw and drinking through that. And his biopsies again showed eosinophilia. And I think the lesson from this is that EoE really is a chronic disease requiring chronic treatment and long-term follow-up. In the menu here of what was asked to be discussed during this presentation, we'll go over the historical context, diagnostic approach, importance of monitoring, and some unexplored questions that will hopefully help to set the stage for many of the excellent other presentations that will be presented during this program. Let's focus on historical context because this really is a great story to tell, a history lesson of eosinophilic esophagitis that embeds many of the important features that we think about as a part of our clinical care as well as academic medicine. Going back to 1982, eosinophils were initially associated with reflux disease in this seminal work that was published by Harlan Winter and colleagues in 1982. He identified 46 children from a variety of different age groups and showed that histologically these patients had eosinophils present that were highly specific for GERD and a well-defined population of patients. In 1985, this was a follow-up study performed by Dr. Shub and colleagues in which they identified esophagitis as a frequent consequence of reflux during infancy. On the y-axis, you can see the numbers of eosinophils in mucosal biopsy, and on the x-axis, the number of neutrophils. And I think what one can appreciate is that there are a large numbers of eosinophils present in reflux disease. But interestingly, there is another group of patients who have a very large number of eosinophils, making one wonder whether eosinophilic esophagitis may have been present back in the early 80s. In 1993 and 4, these two seminal publications were published by Drs. Atwood and Strauman in two different institutions, one in the U.S., one in Switzerland, in which they described adults who had symptoms of dysphagia, increased numbers of eosinophils in the esophageal mucosa, normal pH monitoring in Dr. Atwood's study, and what Dr. Straumann described as idiopathic eosinophilic esophagitis, a frequently overlooked disease with typical clinical aspects and discrete endoscopic findings. Soon thereafter, Kelly and colleagues published this important work that showed not only the presence of this condition in children, but also the therapeutic intervention of using an elemental formula. They had 10 children who had reflux-like symptoms, increased numbers of eosinophils in the mucosa, and this resolved with the use of elemental formula. One can see that very inflamed esophageal epithelium here, and that resolved with the use of elemental formula. Following this, we published our findings of the histology associated with EoE. And on the left-hand side, you can see the distance above the gastroesophageal junction where biopsies were obtained, and the different histological features, including aggregates and superficial location. The orange box demonstrates patients numbering 21 who had normal pH monitoring or symptoms that were refractory to PPI use. And in group C in the blue were patients who had well-defined reflux disease. And what I think you can appreciate is the fact that there were an increased numbers of eosinophils in groups A and B, those who had eosinophilic esophagitis, compared to those with reflux, and the characteristic features that we've associated now with EoE, including aggregates and the superficial location of the eosinophils, were only seen in those with EoE and not those with reflux disease. In 2004, Dr. Vieira published this important work that helped to raise this importance of doing endoscopy to help us differentiate patients who may have reflux disease from those with eosinophilic esophagitis, with upwards of 5% of patients having severe esophagitis and likely EoE. In 2007, Dr. Dillon and others identified the fact that there was a wide disparity amongst how eosinophils were actually assessed in the literature to date concerning patients who had eosinophilic esophagitis. If you look on the y-axis, this is the number of publications. On the x-axis, the numbers of eosinophils used as a diagnostic endpoint in studies. And in fact, over a third of these studies really never even reported a number. Importantly, one can see also that the size of the high-power field was also not identified, making the numbers somewhat of a challenge to help us understand and assess as a disease biomarker. To address this, the first EoE diagnostic guidelines were discussed at the first NASP Begins Single Topic Conference in 2006 and then subsequently published in Gastroenterology in 2007. And these guidelines identified the fact that the diagnosis rested on having symptoms associated with esophageal dysfunction, greater than 15 eosinophils in one high-power field that was well-defined, and a lack of responsiveness to high-dose PPIs or normal pH monitoring. And these last two were present to try to separate out these patients from those with reflux disease, and at that time were felt to be the best way to do that. In addition, other causes of the esophageal eosinophilia needed to be ruled out, as shown here. The typical features are with increased numbers of eosinophils in the epithelium are presented here, and in a higher power view you can see not only the increased numbers but degranulation and dilated intercellular spaces. This is a really important study also that from Brazil that helped us to understand that we need to make sure that this diagnosis is strongly considered whenever symptoms associated with reflux do not respond to conventional treatment. And in 2018, there was the removal of PPIs from the diagnostic criteria based on increasing amounts of clinical experience, as well as a number of different studies. And you can see that this was recommended in a series of different guidelines in the American College of Gastroenterology, in the European Journal of Gastroenterology, as well as in Gastroenterology. And this was largely based on the fact that there were scientific findings that actually PPIs could decrease the chemokines that were necessary for eosinophils to influx into the epithelium. One can see here on the y-axis the eotaxin 3 concentration, on the x-axis a series of different conditions in which eosinophilic esophagitis squamous epithelial cells were incubated with the stimulators IL-13 and 5 and treated with omeprazole, showing that there was a decrease in the concentrations of eotaxin. Well, in 2013 and in the intervening years, despite the fact that we had diagnostic criteria, it was still very clear that there was a delay in diagnosis, likely because we had not been able to proliferate this information as fully as would need to be. Here was an article in Brazil that showed that there were 11 patients who had a diagnostic delay of up to 3.5 years, and this has been shown in other publications since that time in Mexico, as well as other Latin countries. In 2018, this was an interesting study in which in a Mexican population of patients, it seemed that the numbers of patients who presented with food impaction were not the same as they were in the United States. And the reasons for this are not certain, but in the United States, it was upward of 50%, and in this group, it was much lower. And then finally, our Brazilian colleagues again published a work saying, so where are we today in 2018, and what needs to happen next? Well, the most recent developments have occurred in both 2020 and 2025, in which in 2020 the AGA published this first joint task force assessment of the clinical guidelines for diagnosis and management of EoE, a real seminal publication. And then most recently, just at the beginning of this year, the American College published the clinical guidelines for diagnosis and management of EoE. What did this last publication state? First was there was the advice to elicit a careful history of esophageal dysfunction, something that we may not be as keen on doing, but it need to include, have you modified diet or provided modification behaviors? The second was that we need to make sure that we assess the family history and see whether other comorbid atopic features are present in the patients, and that endoscopy should be performed off of treatment so that we can really understand whether or not this disease is present. And there are a number of other features that are emphasized here in this diagnostic guide. So then just this week, there was a publication showing that there continues to be an increasing clinical experience and findings in Latin America. This is a publication from Mexico that showed 32 patients were identified from 12 states of Mexico, and these were patients who were all cared for by allergists. The patients ranged in age from 1.5 years to 17 years, and typical as all studies, they had a male predominance. The average delay was about 15.5 months, so hopefully we're doing better in that regard. The presenting symptoms were food impaction and feeding difficulties. It was normal appearing mucosa in 2/3, perhaps indicating earlier diagnostic interventions. And then the very interesting finding that IgG4 positive cells were present in 75% of the patients, suggesting this may be one of the underlying pathogenetic findings that's going to need more and more investigation. So I think the second point I'd provide to you is that during the last 45 years, clinical observations and research has shaped our current diagnostic approaches. This has not remained a static process, one that has changed over time, and I think has really helped us to improve care, leading to earlier diagnosis. Well, now let's turn our approach into what are the diagnostic approaches that need to be taken. The diagnosis, as we've mentioned before, relies on the symptoms that include difficulty in swallowing and others that are shown here. The abnormal appearing mucosa, I think, will become emerging as a new approach to thinking about the diagnostic criteria associated with EoE. I really like this presentation from the Espegan group, in which they showed this progression and perhaps changing of how symptoms may present it. On the far left-hand side are young children who may present with vomiting and growth failure, and as patients get older and perhaps they're increasing in their different kinds of food textures, dysphagia and food impaction become much more common. The histological features are really well known to all of you, but shown here are the microabscesses and their endoscopic representation of the white exudates. The ERF score has become a very important part of assessing all patients who have eosinophilic esophagitis, in that they not only can help with diagnoses, but also in the sense of identifying therapeutic monitoring and success. It's keyed on 5 different features, including edema, rings, exudate, and furrows, and stricture. Each one of those can be graded, and I think you can see the worst findings here on the far right-hand side of those different features with rings and exudates and furrows that demonstrate their impressive characteristics. In addition, there has been now developed a eosinophilic esophagitis histological scoring system developed by Margaret Collins. On the left-hand side, you can see all the different features that do not just focus on the eosinophil numbers, but rather on the state of eosinophilia, as well as other features of epithelial dysmorphic features. And when you look at the tissue itself, this is not just going to focus on one aspect, but actually how extensive is the finding and how significant is the finding. So important way to score the system. I think this is hopefully something that we'll be able to enter into many of our clinical assessments, but certainly has been helpful in research studies. This scoring system was evaluated by the Brazilian group in clinical to see what the clinical effectiveness of that was, and I think to say, was this something that could be used not only in an academic center, not only in an academic center in North America, but how transferable is this to other practice? And so the group looked at the 8 features with respect to the grade and severity and the stage of the extent, the maximum score of 24, and found that the inter and intra-observer agreement for the eosinophil counts were high, and that no training was really needed for the use of this system. So I think this is a system that is transferable and hopefully going to be quite useful in the future for clinical use. I wanted to make and emphasize the fact that eosinophilic esophagitis is indeed a swallowing problem, and one that we really want to make sure we dive deep into when we're assessing the history of our patients. For instance, and we know that younger children have eating problems, vomiting and pain, adolescents dysphagia and food impactions, and as I mentioned before, these coping mechanisms that develop may hide some of the symptoms overall. So when a patient is asked, do you have any swallowing problems, the answer may indeed be no, but if you go on to ask a series of additional questions, such as do you cut your food in small pieces, chew the food a lot, pocket the food, keep the food in your cheek, need liquids or other kinds of lubricants to eat your foods, or avoid certain highly textured foods such as meats, breads, rice, or potatoes, the answer may indeed be yes. And whether it's the child or the family that's asked these, it can be quite revealing. In addition, you may ask the question of, had you had a food impaction or food stuck in your throat? And again, the answer may be no, but if you go through and ask a series of additional questions, such as, do you jump up and down after eating? Raise your arms above your head after you feel that food is stuck. Avoid eating in public, or wet or lubricate your foods. The answer may be yes. And these are all real-life examples from patients that I have seen. Let's think about, again, a patient and how important it is to ask these questions. This is a patient who is I called the anxious basketball player. He was a 17-year-old boy who had food allergies and a lot of anxiety around eating. He just didn't want to eat foods. And these eating problems were present for as long as he could remember, but he would never really describe them more, nor was he questioned very much about them. But when we spent some time talking about this, he said that he really experienced daily fear of swallowing and worried about this in particular in social settings. He could not swallow pills. He did not like to eat meat or highly textured foods. And in this regard, the allergist was the one who really thought about this disease because of his prominent history of food allergies and wondered whether it may be the case and referred him over for an evaluation. And our initial evaluation was an esophagram, and one can see here that, again, a very small, narrow caliber esophagus, and our practice is all bring up in a few minutes. We use a barium pill to assess the motility. And in fact, this barium pill that was offered was declined because he was not able to swallow the tablets. When we looked at him endoscopically, you can appreciate again a very narrow esophagus. It was 7 millimeters. There was a tear present after the dilation, as is shown here. His tissue showed increased numbers of intraepithelial eosinophilia as well of intraepithelial eosinophils as well as laminar propria fibrosis, and we started him on topical steroids. And I think the point of this was it really did take the allergist to think and to ask questions to help this young man who had been suffering for years to finally obtain a diagnosis. Well, let's think about some new and perhaps old diagnostic techniques that can be helpful in your assessment of eosinophilic esophagitis. And I think when we're thinking about this, it's quite challenging because in this figure from the AGA, the esophagus is a very hidden organ. It's in the middle of the chest. We can't examine it physically. It takes endoscopy, and so how can we really assess the esophagitis in patients who have EoE? And I think from a symptom standpoint, and because we now have the EREF system and we have the eosinophilic esophagitis histological scoring system, there was an effort to try to track disease severity as a matter of clinical practice, not necessarily needing to be in a research study, but one that was a way of doing this in the office. And this was another one of the good outcomes of COVID. It was developed virtually all online by all the different investigators shown here in collaboration with the AGA and CIGR, the Consortium for Eosinophilic GI Researchers, to identify an index of severity. And through those discussions, an app was developed as shown here, and you can download this from your app store. If you go there now, put in I-SEE and AGA, this will pop up. It takes less than a minute to use in your practice, and I think is quite a valuable tool. And that tool helps to integrate these questions. So we want to know about what are the presence of symptoms and all the different things on the left-hand side as a part of the grading. So symptoms and complications, features of inflammatory disease, endoscopic and histologic, and fibrostenotic disease, again, endoscopic or histologic. On the top shows the scoring of that, ranging from 1 to 15 points, and depending on the severity, this is what has been seen. And so I think with the patient that we just discussed, as well as this patient who is shown here, you can see that the patient had multiple times per day of having symptoms, leading to 4 points. Diffuse inflammatory features, both endoscopic as well as histologic, and fibrostenotic features were present. So it gives us a way of assessing disease activity before treatment is started and then afterwards. And this has now been studied in a number of different patient populations, including children and adults, shown to be quite effective in assessing symptoms. And in this most recent paper by Sato and Shoda, has been shown to not only correlate with disease activity, but also with genetic patterns. So think this is going to be a really exciting tool going forward. Why is it important for us to have all these different kinds of ways outside of just asking questions? And the bottom line is, and this is no surprise to any of us, but that symptoms don't match histology. And in this work done by Safraneva and colleagues, they were able to show that the ESI, using the ESI PRO score, there was a real lack of accuracy and correlation between symptoms as well as histological activity, and meaning that we do need to find better ways to assess this overall. We've seen patients who have very significant symptoms who may have a normal histology, and those patients may have something called esophageal hypervigilance, and those who have very few symptoms but very abnormal histology. And so we need to think about and continue to innovate new ways to assess our patients. And what might those be? And here are at least 4 of those that we'll describe in a little bit more detail, related to radiologic examination with an esophagram, the minimally invasive cytosponge, and endoscopically ways to assess the disease activity, including transnasal endoscopy and endoflip. So you brought up radiographs several times now, and why is that so important? I think we're familiar with the fact that you can have proximal esophageal narrowing that can be either focal or diffuse, and shown on the right-hand side is diffuse narrowing of the proximal esophagus in a patient who has eosinophilic esophagitis. Well, Natalie Nguyen and Caliste Menard-Ketcher in our group has looked at this more closely and identified the fact that the esophagram itself is very vital because of the fact that when we assess a number of our patients who had eosinophilic esophagitis, have been assessed both endoscopically as well as radiographically, that up to 55% of the time a stricture was not identified at the time of endoscopy, but was at the time of radiographic examination. And in fact, the barium pill, as shown on the left-hand side, was vital in helping us understand that narrowing feature. Hence the evaluation that I described earlier with our patient of having them actually try to swallow the pill. And it's quite telling if at the time of radiograph examination the patient refuses to swallow a pill. This could be a good or a good indicator that perhaps there is a narrowing that's present. So pill esophagams can really be helpful in identifying occult narrowing. The second is transnasal endoscopy, and I think this was really developed and pioneered by Joel Friedlander, who recognized that the use of traditional endoscopy can be so problematic, in particular with a patient who has on dietary therapy. And this is a study that was done by Lucendo and colleagues in Spain, in which they had patients go through a series of different food trials, and at the end of each trial or food addition, an endoscopy is performed, and you can just appreciate the fact that that's quite a bit of procedures for a patient, in particular for a child, and cost, safety, quality of life, and really the limited assessment that can be assessed with a mucosal biopsy is quite concerning. And because of that, Joel developed the approach of using transnasal endoscopy, so a scope that was 3 to 4 millimeters in size as opposed to the traditional 9 millimeters inside, to go through the nose in an unsedated fashion, but with topical anesthesia to assess the esophageal mucosa. And this has now been done certainly at a number of different centers across the United States. This is work, a review that was conducted by Natalie Nguyen and Jake Mark in our group that showed the passage of the endoscope into the nares. You can see in B just prior to passage through to the side of the airway, and then the appearance of the esophageal epithelium. The biopsies that are obtained can be shown here, and the endoscopic below. The biopsies have been shown to be statistically significantly the same as those obtained during traditional endoscopy, and you can see the size of those on the left-hand side of those from a transnasal scope and the right-hand side from a traditional endoscope. And as I said, no significant differences in the size of those biopsies. So we think this is an approach that is viable and is quite helpful in assessing our patients for a number of different reasons. The adverse events associated with this is quite minimal. Nothing. We've had no serious adverse events with that to date. We think about what other ways to assess the esophageal mucosa that may be even more minimally invasive. One can see the side of sponge shown here, and this is a capsule-based technology in which the capsule shown on the right-hand side of the picture is filled with a sponge. The sponge is shown on the left-hand side that is attached to the string, and this sponge is, the capsule is swallowed, the capsule dissolves, and then the sponge is pulled back through the esophagus, obtaining tissue fragments that can lead to samples as shown here that can be formed into a tissue section and then stained for eosinophil granuloproteins, in this case eosinophil-derived neurotoxin. And in the bottom right-hand panel, panel D, one can see the increased numbers of eosinophils present. So really a quite nice way of assessing the esophageal mucosa without having to do the attendant endoscopic assessment. And then finally, I wanted to bring up the EndoFlip, which is a newer technology in which one can see on the left-hand side the tracing, on the middle panel the catheter itself that is passed into the esophagus and insufflated, and on the far right-hand side you can see the tracing encompassing the body as well as the lower esophageal sphincter. This is a picture from Khalees Bernard Ketcher showing on the right-hand side the deflated balloon, and inside you can see the monitoring sensors. On the right-hand side, you can see when this balloon has been insufflated with buffer, and when this is in the esophagus, the distensibility or the tension placed on the balloon can then be sensed by those sensors on the catheter itself and be related back to form a tracing as shown here. And on the top you can see the endoscopic appearance, on the bottom the EndoFlip signals or the patterns that are present. On the far right hand side you can appreciate the narrowed appearance of a patient who has approximately 9 millimeter stricture. Well, how is this useful in work that Khalees Bernard Ketcher and Amanda Muir have done? On the left-hand panel, one can see the diameter on the y-axis and age on the x-axis, and the patients with eosinophilic esophagitis in orange, those who do not in black. And I think you can appreciate the fact that these EndoFlip tracing signals are able to show that the diameter of patients who do not have eosinophilic esophagitis are significantly greater than those who have eosinophilic esophagitis at the same age. One can see on the right-hand side, this is shown again over all the patients, and that is a statistically significant difference in the size of the esophagus in these patients. And secondly, they're able to show that the diameter shown on the left-hand side on the y-axis compared to eosinophil counts on the x-axis, there is a correlation with the eosinophil count. That is to say that the higher the eosinophil count, the less distensible the esophagus is. So in these patients studied that the higher the eosinophils, the smaller the diameter, giving us again a readout that could be quite useful. So the third point is that innovative techniques have really allowed us to better understand esophageal function and potential pathophysiology, but more research is clearly needed. Well, why is it so important for us to even think about monitoring? Or we've got these interesting types of devices, but do we really need to use them outside of the diagnostic sphere? And I would say the answer to that is yes. And here's a slide showing that EoE continues to be a major problem. So we're not to the point where we're capturing all the patients that we need to from a diagnostic standpoint. And this is a global study that was done by Hahn and colleagues. On the left-hand side shows that there was a meta-analysis done of 288 million participants. The global incidence of EoE was found to be about 5.31 with a prevalence of 40 per 100,000. You can see in the middle panel of the global map that this does occur across the world, perhaps not in some countries, I think likely because we have not been able to assess them to date, but on the right-hand side showing the time trends of the prevalence of this disease and how it is continuing to increase and making us aware of the fact that these patients are present, and we need to identify them, and we really need to monitor them over time. And I think this is really emphasized by this work that was done by Yam and colleague in which they wanted to see what the burden of eosinophilic esophagitis was as it related to food impaction. So on the left-hand side, there is the statement of they looked at almost 50,000 patients who had gone to the emergency room who had eosinophilic esophagitis. And on the middle panel, you can see that over time, that this really continued to increase. So every year that this was assessed, when they divided all these patients up, that there was a continual increase in the numbers. And then they went on to forecast that over the next decades, and shown that the projection is that this number will double again by 2030, suggesting there are going to be greater than 700,000 patients who will go to the emergency room for dysphagia or food impaction and who receive the diagnosis of eosinophilic esophagitis. So important for us to know, because these patients need to be not only detected but followed to make sure they're in remission so they don't have recurrence of this problematic event. The American Society of Gastrointestinal Endoscopy has published a guideline in 2022. I think the bottom line from this is a chronic disease, requires chronic treatment and assessment. And the 20th recommendation of this was that continuous monitoring should be performed, and likely endoscopy should be done to assess the mucosa. But this is in many ways going to be left to providers to see how often and when that, or the depth of investigation that should be done. So patients indeed need to be followed within your practice. The frequency of endoscopy, whether that's yearly or every other year, I think is yet to be determined, but we want to make sure that patients are in remission so we prevent those food impactions from happening. Just as a preamble, later this year there will be the second edition of this that will be coming out, and so stay tuned for that, because I think it'll provide some more additional advice as to what to do in monitoring patients. So the fourth point is that follow-up of EoE patients and patients with food impaction will certainly improve their quality of life, and work done by Schofer and colleagues showed that the more treatment, the less frequent that food impactions can occur. Well, let's close with just a few unexplored questions, and I think this will hopefully, many of these things will be addressed in upcoming sessions within this webinar series and looking at the titles. But, I think one of the important things to think about is that eosinophilic esophagitis it has a certain diagnostic criteria, but I think we're learning more and more now that there's not just one kind of eosinophilic esophagitis. And in this study that was done by Andre and colleagues, they looked at 256 patients who had EoE, who were in the pediatric, about a quarter in the pediatric age group, and they found that just over half had fibrotic disease at the presentation, and then they had long duration of symptoms, but less than half really had only inflammatory disease at that time, and very few of those patients went on to develop fibrostenotic disease. Now, whether that's because they got treated or whether that's dictated by genes, I don't think we know that yet, but work from Seeger and others has identified the fact that there are different endotypes associated with EoE, and that this there may be patients that continue to be purely inflammatory and never progress to fibrostenotic, and vice versa. And therapeutically, there are likely patients who have different kinds of responses. So those that are diet responsive and not, and those that are steroid responsive or not also. We want to continue to develop these new technologies, as I've discussed previously, to really understand the pathogenesis, improve care. And I wanted to just give you these 3 slides as, again, a preamble for other talks to come. But just to say, it's really a great part of the history of EoE that we now have a long history of diet treatment success, over 3 decades of this. And all the landmark studies are shown here that include, as we started the talk with, the elemental diet, and now all the way up to likely one food elimination diet. But a lot of work has been done in this, and so we can feel really good about prescribing a dietary therapy for our patients. The second is we have a long history of the use of topical steroids for eosinophilic esophagitis. Now, almost 3 decades worth of this, from the initial observation by Fabian and Fries, in which they noted that the topical use can be helpful in 4 patients with EoE, all the way now to the point where we have an FDA and EMA approved topical treatments for eosinophilic esophagitis with steroids. And that is with minimal amounts of side effects. And then finally, I think probably one of the very exciting parts of the work that's been done is that there's a long history now, 4 decades, of the development of a biologic for EoE. And this goes all the way back to the 1980s when IL-4 was discovered, all the way to now when we have this biologic that can be used. And this shows that great progression of discovery, testing in vitro models, mouse models, phase 1, 2, and eventually 3 studies. So we have another additional therapeutic option for our patients. So I think the future, and what do we need to continue to do, and we want to really encourage all of our young colleagues to advance on, or we need new treatments and approaches, those that are biologically sound, that we'll understand more of as we understand more about the pathogenesis, those that can have good adherence, so those that can be hopefully, maybe a once a month pill type of treatment, or something that's going to be less burdensome. Those that are financially feasible, and obviously we want to make sure that the treatments are not worse than the disease itself. A treatment paradigm. We started with IBD, we'll end with IBD, to show on the left-hand side. This is a well-developed now, I think, paradigm of how do we treat our patients with inflammatory bowel diseases. And in this work by Salvatore Olive, he's really emphasized the fact that we're not there yet with eosinophilic esophagitis. We certainly have a number of ways to treat our patients successfully, but is it a step-up approach? Is it a top-down approach? What's going to be the best way to do this? And I think we'll know more about this in the future. So to summarize, I would say keep making these careful observations that help us identify our patients and make a diagnosis, as was done early on in the historical elements of this disease. The second is ask the detailed questions and use technology to its benefit to help us improve the care of our patients. And doesn't mean that every patient needs to have an endoflip, but when there are patients that have things that need to be more and better understood, we want to advance in using these different kinds of technology and developing new forms. We want to follow up our patients regularly to make sure that we don't have food impactions occurring, that one fear complication, and then think innovate and be visionary to continue to advance our care going forward. A reminder that there are a number of different advocacy groups that have online materials that are very helpful for us as providers, as well as for our patients. APFEG, CURID, the Eosinophil Family Coalition, EO's network, and I apologize for not having that on here, but Aussie from Australia is another advocacy group that is quite helpful. I would like to end just by saying thank you to all of my colleagues who I've been able to show much of their work in the Digestive Health Institute and Children's Hospital of Colorado, our eosinophilic diseases program shown on the left-hand side, Joanne Masterson and the work that she's doing in Ireland, our close collaborator, and all those in the Seeger Consortium. The funding for the work is shown in the upper right-hand side. So thank you so much for asking me to present today. I am grateful for this opportunity and wish you a very successful webinar series.